I'm glad to see so many of you up bright and early, eating breakfast, and ready for the second great day here. Program and great content. First, thank you for coming for breakfast and being up so early, but wasn't that a great program last night with the Edelman presentation and all the contests? That was outstanding, I thought. I'd like to really recognize the winners from last night. FCC winning the Edelman, what an awesome program and a story they told, and $7 billion back to handle the deficit of the government. I mean, how many teams have ever said that, right? $7 billion back. That was awesome. University of Tennessee for the UPS George Smith Prize. I'm sure Bruce will be glad to hear that University of Tennessee won that prize. The Wagner Prize, Lehigh, my alma mater, and Tomas Terlaki and his team did a great job. Nice going, Tomas. And Inform's Prize, what a huge prize, taking sometimes up to a decade or more of evidence and proof and hard work going to BNSF. Sorry, I always mess that up. Great job there, and they're also one of our best sponsors, so thank you very much. So how about a round of applause for all of those great winners announced last night. A little bit of housekeeping today. Number one is today is our fewer receptions and more content. So that's, I think, great news. There were a lot of receptions yesterday, and we're really happy that we have really solid tracks today of 5 very hand-picked speakers. So please get to as many of those talks as you can. There's a couple minor changes in the emerging analytics track. Track 16 starts at 9 a.m. or 9:10 right after this talk. Muj Kappen from Drexel University is going to be talking using advanced analytics in healthcare to predict sepsis risk and patient outcome. And then Gertjan de Long from Ames is going to be speaking at 11:30 in the same track. So they're switching spots at the intersection of OR and data science, opportunities, challenges, and innovation. So that's within that track. There's just some speaker changes positions. Also, the analytics leadership track is going out today as well, and what we're going to do there is, since we don't have a lot of time for question and answer for Bruce Greenstein, he's actually going to be there at that talk, and at the end of the talk they're going to have kind of a fireside chat as well with I think, Bruce, you're going to invite some questions and answers at that time, right? Great. So that's really great for our keynote speaker to also go to that track and invite some questions and answers. And then I'd also like, for those of you who didn't see yesterday, the poster session is continuing on today with brand new posters. So please pass by there. I think you saw how quick and easy it is, and the way they have them labeled, to pick out some posters that might be of interest to you and read through those. A really quick way to find some very interesting work going on. All right, now for our keynote speaker. I'm really honored to be able to present our next keynote speaker, Bruce Greenstein, who is the CTO, Chief Technical Officer of Health and Human Services for the U.S. government. Reading through the slides and talking to Bruce, this is going to be a really amazing talk, and I hope it's not a spoiler to say that I found out that this is that HHS is the largest government agency in the world. Pretty amazing. So Bruce has a real health-oriented history, all the way back from when he went to school at Florida State and University of Tennessee, and then had some healthcare policy jobs before then working for Microsoft as the managing director for worldwide health. Leaving Microsoft, he went to Louisiana, and where he was I may have this slightly different order, but where he was the secretary for health and hospitals for Louisiana. Now, he's also been in the private sector where he was CEO of Blend Health, and he was president of Quartet Health, which is an amazing company that has done a lot of good analytics and continues to do good analytics work with health records and behavior health. So then he was brought back to become the CTO for his current position in Human Health Services. We are really happy to have Bruce come and talk to us today. He's a great speaker and has a lot of good info for you. Bruce, thank you very much for taking time out of your day and coming here.
Thank you, Bruce. Thank you very much. All right, good morning, everyone. Come on, 8 o'clock in the morning. I had to drive here. I've been up since about 5. But what's really, two things that I'm really excited about. One is I get to talk about my favorite subject, data and government. I know some people are thinking I could go back to sleep now. But the other is that we have an hour to talk about it. And having a full hour to have this discussion is sort of emblematic to what I want to talk about today. It's not often that in government we get a long enough time to have this discussion about the impact of data and technology in changing the way we practice healthcare, the way we govern, the way we run large professional bureaucracies. And as we just discussed here, this is HHS is the largest single department in the entire planet, on the planet. $1.185 trillion spend. And I'm going to go through that in a little bit. So today's discussion, and we're going to save some time for questions at the end, we should be able to go a little bit deeper and have a little bit more of a thoughtful discussion than typical kind of conference 20-minute cycles where you just go through all the things that the government is doing and try to seem like we're on top of all of our problems in the world and not really go deep enough to kind of go over why we have these problems over long periods of time and why don't they get fixed very quickly. And the notion of using data, sharing data, and changing something with it, whether it's some outcomes, the performance of a department, human behavior, that is very tricky and difficult. That's why we're such a large government organization, because we pay for healthcare. We have a lot of health problems that we address. So let me start out at the top. Let's go through a little bit about what this place is and what changing the culture and dynamics and working operations is like. So this is our headquarters in Washington, D.C., the Humphrey Building, HHS, the second ugliest building in Washington, D.C., in a city that is replete with some of the most beautiful and grand architecture. The largest government agency is headquartered in the second ugliest building, represented by the brutalist architecture. Interestingly enough, for those that spend time in D.C., the ugliest building is the Department of Housing and Urban Development, which excels this building by only a little bit and probably built, I think, within the same 3 or 4 years in the same architectural style. Now, while it might not look great on the outside, on the inside there's a lot going on. Headquarters for about 80,000 FTEs, so badged employees with more than 100,000 contractors that lie beneath that in different agencies. In other countries around the world, these 4 agencies that I listed out would easily be their own standalone government departments. In fact, in the United States, it would be perfectly plausible for any of these agencies to be their own department. And I'll just give you the first one, CMS, which is the Medicare and Medicaid agency. And so keep in mind, we spent $1.150 trillion last year. This year, it's $1.185 trillion. And when you do some numbers behind the point, you're like, yeah, it's not that big. But we're talking about hundreds of billions of dollars after the decimal point when I say trillions. So in the first one, Medicare, Medicaid, one service within CMS, which is end-stage renal disease for people with kidney failure. So the dialysis service. One service costs more than the entire space program, all of NASA's budget, or it's larger than the entire Department of Commerce and budget. So that's just one service in one agency in the department, just to give you a sense of scale for how large the department is and how profound the impact and reach is. The FDA, Food and Drug Administration, it covers $1 in $4 that get transacted in the U.S. economy. Not just if you take a script in the morning, not just if you have some kind of FDA-approved device that maybe you've had an operation or you have some part in your body, and not just certain kind of foods. This is a quarter of the entire activity of the U.S. economy gets regulated through the FDA. NIH, by far the world's largest biotech research organization, funds so much of the research and discovery that changes health on the entire planet. And then the CDC. It sounds like hyperbole to say the CDC has saved the world, because it is a pretty grand statement to make, but I'll just have you jog your memory slightly. Ebola and Zika. We have these large international bodies, I won't name names, that are supposed to go out and address issues and fix problems before they get to be large and out of control. Well, it turns out they don't do a very good job, interestingly enough, because they don't share data. They don't share information well enough, and there's a lot of cover-up that goes on. Oh, people aren't getting sick. It's not that bad. And when things really get bad, there's a whole group of people in Atlanta at the CDC, which is where the headquarters for that organization is. They keep duffel bags packed by the front door. And these are some of the most selfless and proud to serve people that work in our department. They board planes and they're gone from their home and family for months at a time in usually very difficult situations, trying to put an end or eradicate or stop the spread of some type of disease that poses a major international threat. And so again, Zika and Ebola seem like, oh, no problem. The country said we got it under control, a couple cases, don't worry about it. Other countries around it, oh, we don't see anything, because of the fear of disrupting commerce and travel and causing fear within their own countries. Things get out of hand, and then we send in the troops. So yeah, CDC, save the world, a couple times in the last 10 years or so. Then we have a whole number of other agencies that do research and mental health and rural health. And in other countries, they would be the size of a whole government agency. Here, it's too many even to list on one page. But the scope is more than 27 agencies within this department. Many of them have their own IT shop. They have their own server stack. They keep their own data separately. This is foreshadowing, because I'm going to get to that part later. But the situation is that all of these agencies operate very independently with a great sense of sovereignty. Many or all of the heads get independently confirmed in the Senate. Their budgets are directly appropriated from Congress, so there's a lot of autonomy. And so this is creating a culture that goes for decades that makes these operations be pretty independent. And again, I'll get back to that. It's part of the story. So what do we care about? So some people wondered when we started in this administration, is there going to be the same interest in open data, in attention to technology, in fueling our economy by using data? And we always like to give the examples that government data such as weather data has really created a whole economy around meteorology. The data that we make available through our satellites and GPS has really changed the way we navigate around the planet in a very, very good way. Well, whether it's the White House, whether it's OMB, and there's a group of people in this OMB slide that are from our office that participate and provide leadership. Our new Secretary of the Department of Health and Human Services, very pro-data, very pro-sharing data. And it was reassuring. It was one of the reasons I came back to Washington, D.C., that there's an agenda for using data to fuel the U.S. economy. That's what it's about. It's being as open and transparent with these data, putting it in the right hands, maintaining privacy and security, but to fuel innovation. And that was really exciting for me. And that's really what we're doing. We use it in a number of ways to solve and address a number of problems. The Secretary, again, I have a new boss. I'm really excited to work with him. I've worked with him in the past in Washington, D.C. And then Alex Azar was the head of Eli Lilly for about 9 years. And so he has incredible business sense and acumen. And he brings that kind of disciplined approach to our department. 90 days in, perfect. You know, if everybody's read the first 90 days, the Harvard Business Review book, he comes up with these conclusions. Where are we going to double down? Where are we going to focus? And so, opioids. Opioids is, to some degree, a data problem when it comes down to figuring out solutions, and I'm going to get into that in this presentation. Addressing the high cost of prescription drugs. It's not just by passing laws that says that you have to take every drug price, divide by 2, and then that's the new price. Instead, it's about transparency. How do you put competition to work? How do you put the availability of information out in a publicly consumable way so that those that purchase drugs, like health plans, large employers, and individuals can make better choices? So again, there's a data play here. It's actually a very, very sophisticated data play that we're not very good at today. The high cost of health insurance. Again, the more information we make available, the easier it is for people in large organizations to make better decisions, using information to create more competition to drive down prices. And then this last piece, which is around creating a value-based healthcare system, we're well on our way. This road we've been moving down for quite a while, and it's about, instead of paying hospitals and doctors and other providers every time they provide a service in the old fee-for-service world, instead we move risk to take care of patients' total health to a health system or a health plan, and then they manage in a much more effective way how to deliver those services by keeping people healthier to start with, by moving them through the healthcare system instead of having every entity in that healthcare supply chain stop to get as much of the income out of that individual or that episode as possible. Instead, we want to bundle more up. So guess what? That's a data play as well. The more that we know, the better we can target where to put resources, whether it's on people or high-cost areas, and that's where we will achieve the most savings. Under the Secretary, we have our office, and this gets back to the culture story that I'm going to be telling. Our office spans the entire department, and the office is really built around addressing technology and innovation issues. And it's really exciting. So on the one hand, we don't have a set of regulations that we publish, and we don't pay for certain services. All those offices, they have regular responsibilities, and they basically are attending to the specific issue or department or agency within the department that they regulate. Instead, we're really charged with making everything work better, be smarter, be more efficient. It's grandiose terms, really hard to execute against unless people are paying attention and they're forced to change. Forcing people to change is difficult. I give the example of the great paradigms. Has anybody ever heard of the term paradigm shift? By raise of hands. Okay, right, everyone. It's like a classic MBA term, except you know what? It doesn't really exist. There's no such thing as a paradigm shift. The book, the author is Thomas Kuhn, where this concept comes from. 1957, writes a book called The Structure of Scientific Revolutions. And it's really in the philosophy of science that this book was written. And it really gets to the heart of how do we change the way we think about things. So the very basic classic example is the world is flat, the world is a sphere. There's no shift. You didn't go for, oh, well, maybe it's curved at the edges. Maybe you sort of fall off, but you pop back up if you're in a boat. No, one concept had vigorous and this vigorous competition and debate against the other. You were on the side of Copernicus or Ptolemy. Well, so the sun is at the center or the earth is at the center. In the world of paradigm shift, they would say, well, let's make Mercury in the center for a couple years until we could really prove it out. No. One competes against the other. They don't exist together. There is no shift. That's malarkey. So think about what we're trying to do in the way government acts and behaves with the use of data. There are people that will continue to make decisions the way they did last year and the year before and 10 years before that with the same information. And then there's this whole other way of thinking that says, no, data-driven decisions is not just a bumper sticker, it's a full set of behaviors that needs analytics. If you're going to do analytics, you need data. If you have data, it has to be relevant, which means you're going to have to share more data to make it impactful. That is easy to say, very hard to do, though. That's a major cultural shift, which will take over time. But we are locked in this vigorous paradigm battle right now. Because people that are making decisions without good data, without insights, without analytics, they can continue to do it the way they want to do. They're comfortable with the earth at the center. The math actually works out if you look back at the models. But then when the new model, which has a math set of proofs that look pretty similar, but just happens to be that the sun is at the center, that's the right way. That's enlightened. That provides better results. And that's the thing that we're locked in today. Again, we have a lot of support, and I'm going to go through a couple ways that we're going about doing it. The history of it is interesting because maybe 10 years ago, 7, 8 years ago, the idea of open data, sharing data. The guy who had my job to start with is very well known in the healthcare circles. He started a very important and successful EMR, electronic medical records company, and he was super charismatic and very, very smart. And he used to joke, data liberation. I don't know why he decided to use French, maybe because it's like a revolution. But he would go around the country talking about liberate data. And he said, who's with me? Who wants to do open data? And everyone raised their hand. They're just so excited. Yeah, yeah, we all want to. And then the speech is over. He goes home, and everybody goes back to the way they did business before. And so we show up, and like, okay, we're going to just pick up the baton. We're going to go liberate data. And everyone says, yeah, yeah. And then we send out the rest of the team, and we try to get data from people across the department to start addressing problems. And then the excuses come out. Oh, yeah, I believe in liberating data. Yes, open data, I'm all for it. But you can't use mine. It's private. It's secure. There's regulations and HIPAA. So just start somewhere else. And so we did this for a few months and then realized that everyone is also full of baloney. They don't really want to share data. They want to stay comfortable. They want everybody else to share data so they can see theirs, but nobody wants to give up their own. And the excuses that they use are mainly up here. They're artifices. They're not real. They don't have the regulations printed out next to their computer to know what it says. They just think that the person before them said they're not allowed to share, so they don't share. So we're involved in, again, it's part of this cultural battle. It's part of our taking the paradigm and competing against the other paradigm. This is some of the ways we're doing it. One is we're trying to reduce regulation and reduce clinician burden. A couple of examples would be in the FDA. It used to be a requirement to have every digital app that is health-oriented get approval. So if you have a Fitbit, that thing on your phone, that had to get FDA approval. That's one thing. Think about if there's an app that regulates functions with your pacemaker. That seems like that should get approval. That's good. But do you have to get every digital app that has how many steps you walked or your pedometer? Not necessary. So there's a lot of deregulation in terms of what innovations that go through FDA are required for approval. So again, if it's low risk and doesn't impact your health, except if you walk a lot, let's say, but the app doesn't impact your health, no regulation. If, of course, it's a healthcare product, service, or device, it still gets regulation. On the hospital side, over the last 10 years or so, we've asked hospitals to take money to get electronic health records, and in return, they have to give us a whole bunch of new data, quality data and measures and so forth. Well, we asked for a lot of process measures before we knew if it was really useful, if it measured real quality or outcomes. And hospitals and CIOs got pretty tired of producing all this data that just was about process and had nothing to do with the outcomes. So we scaled that back. And people were, interestingly, jubilant over it. You just give them a little bit of deregulation, people go crazy. It's nice to see. We're using information to increase competition. And so it goes back to what I said on the prescription drugs. Well, we're doing this in other parts of the healthcare economy. The more information that we can get into the hands that are the big economic decision makers, the better off we are. I'll give you this kind of this framework to think about. In large corporations on the private side and in large organizations on the public side, take like, let's say, a state government or a school board, large employers. If you look at who manages the investment portfolio for retirement, you will see some of the most decorated and accomplished people in all of state or federal government. Very, very savvy in that domain. Now, you take, let's say, in a school system or state government, those that make the decisions to choose what health plan and health insurance coverage gets done for a population. Bigger investment, bigger obligation, long-term obligations for the health costs. People that are generally not expert at all in that area. Even in companies, we have HR directors that are making massive company-wide decisions that could impact share price that are not expert in healthcare policy or making big, large purchasing decisions, largely because it's an incredibly opaque area. If you do any investing, you can get on any number of services, whether it's Bloomberg or Schwab or, pick your Scottrade, Ameritrade, pick your way of getting information, and it's very, very granular. Try to make a decision on a health plan for your group. It's very, very difficult and opaque. So we're trying to bring on is more information and then give this information in a way to the private sector to develop apps and in general applications and companies around ingesting this information and then serving it up in a way that can be actioned on to create more competition, to lower costs, to make the system more efficient. So this is kind of a nuanced way of getting to some kind of lower prices by bringing the market forces to bear. And then we think about across our department, this is as much of an internal play as it is external play, is making better decisions. And to make better decisions, this is sort of a supplier-induced demand issue. So if you think about if you were Firestone 100 years ago, you were interested in selling a whole load of tires. And if buses were the way that massive amounts of people got around, like every 30 people per bus, that's still 4 tires. But if you could get these people out of the bus, or you can rip up the streetcar lines, you'd have more people driving. And so that was kind of a way to sell more tires, is to get rid of a lot of mass transportation. And that's what they did. For us, we want more people to care about data and analytics. So we present either problems or more analytic tools and make people really excited about doing analytics and visualization and gaining insights. So the more tools that we get out across the department, the more hunger for data that people have. It's kind of our little insidious way of growing a huge user group around the department. So there's a couple ways that we're doing it. What we found, and this is a learning on our behalf, we found that saying analytics and better decision making and data-driven decisions, that wasn't enough. We had to be very, very specific. We had to give absolute examples, and we had to take something that is the most important issue to the country, not just something I happen to like to do or find really interesting. So the opioid epidemic is what we decided to focus on sometime in the early summer of last year. And it's an area where when we went out to the same people that were really concerned about giving us any data, when we told the same people that were the owners of the largest data sets at HHS that they personally can be responsible for saving the lives of people this year, people really started to think about how could I turn my no because of all these reasons to yes if we can do X, Y, and Z. So again, chipping away at the culture of keeping data back, not sharing, and presenting it in a way to provide insights. Let me give all the people that said no to start with a little bit of air cover. HHS is one of the premier organizations in the world on presenting data for its primary use. If you run the national, say, vital records system for births, we have some of the best birth records on the planet. Same thing for death records. If it's immunizations, we have some of the best records that's granular on immunizations. And we present those data beautifully and deeply and 2 or 3 years after the fact. But it's super valid by the time we release it. It's what we don't do. It's the secondary uses of those data across the entire department. It's not enough to present just that one dimension of the data for the purposes that we collect it, although we have to do that and we should do it continue at the same high level. But it's really important to be able to make those data available so that we can do something with it. And I'm going to get into that a little bit. So we use this, this opioid symposium where we brought people in from all over the country that are doing their best to attack the opioid problem and using information as one of their major tools. And it started to change the way people in the department think about the problem, because the death toll is enormous. We know today that opioids this year will kill more people than the highest year ever in gun violence, the worst year ever in the AIDS epidemic, and more ever deaths that occur from automobile accidents. So if you just put it into scale, while it might seem like a problem just in a region in the country, just something that impacts other people not like us, it's not that way at all. It's an incredibly pervasive, disease-driven problem that is manifesting itself in different ways all the time across our country. And so understanding it is the best way that we can make our investments. And I'll show you a couple of dollar figures, how much money that the department is putting out to address it. We have to make sure that those dollars go to the right places for the right purposes to save the most people possible. And so, by the way, this is just forecasting for the next session. Dr. Moni Siddiqui ran this Code-a-Thon. She's giving a session in the next hour. You should go and hear what she has to say, because I'm giving kind of broad overview. If you want to go deep on understanding data challenges and the possibilities at HHS, she's the true expert. So we said that we're doing this Code-a-Thon where data saves lives. Again, going deep on the idea of changing the culture and perception, engaged in this battle, this competition over the paradigms of really using and employing data and just saying it's nice and we'll leave it out there. This is part of the battle. And so what we did is we brought together the relevant data sets in the department, 71 different data sets within HHS, 5 different government agencies. So for an example, the Department of Transportation keeps 911 call data. That call data is a very good way to show how many 911 calls for drug overdoses occur and where, and then how you track them for hospital, emergency department admissions for overdoses, and then connect to death. And then you look at a whole bunch of other things like prescriptions done in that area and a variety of other maybe poverty matters, inpatient admissions, and so forth, to try to understand how this problem tracks. And maybe these pieces don't go together. Turns out it's very difficult to put these data together. What we found was bringing the data together was interesting, and then each data set, no surprise to this crowd, has a data use agreement. Those data use agreements, they make it very difficult to do things with the data to give us deep insights or give us a different type of way of looking at these data to answer questions. In fact, while we had so much cooperation and so much interest, by the time that we ran the Code-a-Thon, working on it for about 3 months of preparation of the data, we were only able to release a few data sets, and every coder, by the way, had to sign forms, and it was limited use agreements, and the data had to go not on their hard drive by the end of the day. A whole number of security matters that are pretty standard. But we only had 3 or 4 data sets that were any different than what you could download from the internet on that same day. So despite all this work and all these assurances and all this curation and security, we still didn't have much that was different than what any of us right now could open up our laptop after the session, open up the laptop, and then go ahead and find those data. So very difficult. Again, drilling down, understanding why it's difficult for that culture to go different. But nonetheless, we put out a ton of data, and interestingly, the surprise rich data sets came from the states that had fewer limitations or were more aggressive in the way that they connected data sets across multiple domains in their own health and welfare and transportation and justice domains in their states. We had 3 tracks for the coders to address, and we were interested to go deeper on treatment, usage, and prevention. We put these data out for teams to answer the call and to do work that we were unable to do. How many people here have been involved in a code-a-thon at all, or hackathon? Okay, good. We try not to use the word hack and healthcare together. Made our attorneys pretty uncomfortable. But you know, it's for the government to do a code-a-thon for something as serious as the opioid epidemic. It's the ultimate expression of humility. Because what it really is, it's a deep admission to being stuck. We don't have all the answers. It's an admission to the fact that the greatest innovation occurring are out there in places that we don't exactly know and we can't put our finger on it. It's an open invitation for the best and the brightest that care about their country and their people to come in on their own time and their own dime to come and do work for the country. It's really, watching it unfold was really a beautiful thing. And getting, you know, coffee for everyone. We ran out of coffee, which was an amateur mistake, but we got coffee at the train station at 1 in the morning. We got more pizza at 3 in the morning. And by the next day, we did this, by the way, inside of that ugly building. And no one there had ever seen anything like this before. And when people came to work the next day and saw all these people in the Great Hall, they walked in and said, "What is that funny smell?" That was funny, actually, because a lot of these guys did stink. Fair amount of college kids. We had schools represented like MIT, Stanford, Harvard, Yale, North Carolina, University of Louisiana, Lafayette was there. We had a couple small companies there like Google, Microsoft, SAP, Palantir that were really sent impressive teams to help think about this as well. And we came up with some pretty cool solutions. Ones that made us think a little bit differently about our own data and what we should be doing. One company that won, I think it was a group that was like a couple small companies and universities that got together. And they had an app that would, just like Starbucks, when you need a coffee, you hit the store button, it tells you the closest one and gives you directions. So we had take-back programs. We know the amount of inventory of opioids is pretty large in the country. People take a couple of their pills, they feel good, they put the rest in the medicine cabinet. All around the country we have way too much that's sitting on shelves and becomes potential. Someone else in the house grabs them, gets hooked, and then bad things start to happen. So take-back programs. What it showed us was deaths, where we track deaths to the zip code level or county level and the number of take-back programs. And we had these vast sets of geography across the country where there were no places to take back drugs safely. So while it presented a great tool for people and families to use to take back drugs, as policymakers it made us think, wow, we need to get on this and start to maybe release a grant program or do something to incent states and communities to set up more take-back programs, and that's happening right now. We did, in the treatment side, to track overdoses. And part of this is a way that we have real-time information served up so that EMS, first responders, can be in the right neighborhoods at the right time. And if you think about the opioid epidemic as a supply chain issue, so many of the overdoses now are coming from illicit drugs, not prescription. And then within that illicit class, it's not just heroin, it's heroin that is laced with fentanyl. And so when you have very bad batches, we're not seeing just one person ODing and ending up in the emergency department per day. We're seeing clusters. And so if we get EMS people out in the right place with the antidote, naloxone, we have a much better shot of keeping people alive. And it actually works pretty well. And the last one is interesting. We all know, how many people here have an academic appointment? Okay, well, we know that a motivating factor is how we do compared to our peers. It's really just human behavior, right? If you're a doctor, it's even worse, as I understand it. And so when we're able to display for an individual clinician what their prescribing habits look like compared to others in their peer group, geographically, so zip code, county, state, and type, it really makes people reconsider what they're doing. If it's proper protocol to be able to being as prescribing as many as they're doing, whether it's number of scripts or morphine equivalent in terms of doses. So this was really, really nice to see. And again, this is a set of solutions that happened over the course of about 48 hours. And what's even more impressive is like 5, 6, 7 teams deep in each of these tracks, we had real nice solutions that have both commercial viability and public policy impact. So another thing, moving on from that for a second, another thing that we're doing across the department to try to seed innovation and try to attract companies, again, this gets back to the cultural revolution we're trying to lead, is around startup days. It's a set of initiatives that we're doing around the country to win back companies that otherwise go right to the private sector and don't think about taking their innovation and addressing the public policy issues in the public sector. And so we're trying to win the attention of some of the most innovative startups that are getting funded, and they put their business plan together. And as I did work in private equity before, I would always ask other companies that I work with, why aren't you going to Washington, D.C. to look for a potential customer? And they said, sales cycle too long. We don't understand the priorities. The process, it's Byzantine. And who do you even call? Like, you can't go on the website and find a woman that runs a program with her phone number and just call her and say, hey, we've got this thing. Can I come in and talk to you? It's really difficult to figure out how to navigate. So we wanted to open up the front doors, put big glass plates in front of HHS to say, hey, easy to come and see what we do. We want to tell you how to get involved and engaged. So we're out around the country trying to explain what we do, make data more available, and make it more interesting for companies to come and address the problems that we have at HHS all across the department. And so far, we're getting the attention of a lot of startups, a lot of incubators, a lot of aggregators of entrepreneurs and startups. And it's really refreshing to see how many people open their eyes and are really excited to work with the FDA or CMS or another, let's say NIH, to submit their own trials for research instead of just doing it in the private sector. So this is just another way that we're addressing the culture at HHS. This is what we did. Again, we discuss opioids all over by making more data available and trying to engage as many organizations. In some cases, it could be other government agencies around the country and innovators and entrepreneurs to address these problems. We were in Boston just a few weeks ago working with for a lot of entrepreneurs there. It's, of course, a hotbed in the biotech world. And we see a lot of interest around innovating ways to address the opioid epidemic. And it was great to be able to get data out and work with companies there. These are some of the winners of different, we have pitches as well within these startup days. And we have startups that bring their innovations to market. They have ways that they're trying to go to market today, and we're trying to get them interested in addressing public markets as well. And here's some of the winners. Again, going back to the opioid crisis, I just want to kind of go through of what we're doing right now. From the very top, it's a major concern. We've been focused on it. Congress has allocated additional money, and here's where we're at this past year. So you could see all in between the various agencies, we're over $1 billion. And this is including monies that we've given out last year. We're within a week of the anniversary of last year's allocation. And in many cases around the country, the money that we gave a year ago is now just getting spent, just getting into the pipeline. And it makes me think, how do we do evaluations? How do we know what our bets are? It makes it very difficult. This year, this is what we're about to do. So new monies go out. So here's what I've been telling people as I travel around the country. Help us make better investments. We're about to go in for another $1 billion in assistance, mostly to states, that will go to agencies that do behavioral health and substance abuse, those that do rural health, and those that do public health. And generally what we do, and having been a former state official, I know how this process works, and it's tricky and it's difficult. Generally what we do is put money into the same solutions that we had before. Maybe it's a community mental health center to do medically assisted therapy. Maybe it's a public health program on education. or another kind of therapy that could be online. But we've been doing the same thing over and over again, and the problem is getting worse. And we're not using our own data to inform us on how to make better investments. I think about all this money, not as just grants. They're investing in communities to try to help communities and families address, avoid, prevent the opioid crisis. And so this, again, is my call for those that think about data, that do data, that can move culture, to rely on data to provide those insights, to give us a better way to allocate resources to save the most number of lives possible. So again, we're trying to seed this supplier-induced demand by making, in this case, we created the Data Science Co-Lab. We also feel if we teach many more people some advanced analytic capabilities, they'll go out and start to look for data, because it gets boring after dealing with one data set for a while. You want more. And then you get to be well known in your domain. It could be on your whole floor in a department. Then you're the person, hey, go see that lady. She's really good at Tableau or whatever the solution that they're using. And then they need more data and answer more problems. So we're trying to spin this up as much as possible. We do training. We did it a couple times. The guy that runs it, really dynamic. He's done a nice job, and we're going to continue to do it again. Again, training this next generation of people to seed our analytics capabilities throughout the department. Within our own department, again, I don't want to take too much of the thunder from the next presentation that Mona will give, but we've started our process within the department, and this is the large overarching campaign in 3 sections. One, we do this thing where we raise awareness, and then we do our research. This first phase is taking us about a year. We're almost finished. We'll be done this summer. And then we move into the enterprise data phase, where we have governance and data use agreements and platforms to do it. And then once everything is in place, we start to action on it. And it starts to change the way decisions are made, allocation gets distributed, and hopefully how people's lives get saved or people's healthcare costs get lower. And right now we're in that process. It's really, really hard. For an organization this large, it just becomes at a factorial level that much more difficult than it would be from a single agency or from a small organization. So come to the next presentation and you can hear all about it. We're also more concerned about how we use our data to interact with the public and how we make our assets available for individuals and researchers and companies that want to use it. And I didn't have that slide that was supposed to be here that says if you go to, oh, there it is, healthdata.gov is our premier website, public facing. We have over 1,900 data sets in it today. We actually just went through a security improvement and a cleansing, taking out broken links and duplications. About 1,000 data sets came off. And what we're interested in is crowdsourcing the best way to deploy data, the most important data sets, what's there that you love and what's not there that you'd like to see. So give us your feedback. You can give feedback in the website. We're going to release healthdata.gov 2.0 later this year, and right now we're soliciting feedback from different domains, different stakeholder groups across the country. And again, it's our public-facing way of providing as much data to fuel the innovation economy, to seed researchers, and to give individuals the best information to make the best decisions possible. Again, we really believe that in healthcare specifically, that data is the lifeblood of our economy. That without making data flow freely and readily available, we're choking the economy, and we're choking competition, and we're raising the cost of healthcare. So if any of you touch healthcare and the work that you do, I hope you kind of take that notion to heart and demand more data, need more information, and then when you get it, put it to good use. We've got about 10 minutes for questions, which I really would love to get some questions and feedback. Now, we don't have another microphone, so if you raise your hand, I'll come to you and I'll repeat the question on the microphone, and then we can go through answering. We have I ran a big sales and marketing organization before. We have a 3-question quota. So we can't leave no more coffee until the quota is met. We can go higher, but we have to have at least 3. So, okay.
How do you feel the universal health care might help the availability of data? Because people are no longer concerned about insurance companies charging them too much or more for pre-existing conditions. So there should be more apt to be willing to share their data. And also, maybe more people might be willing to have their genetics tested, for propensity, things like that, that they might not want out in the public, but now they don't have to worry about the cost of health care insurance, then they should be more willing to get that information, to share it and use it.
That was a super profound question. Thanks for asking. So the question was, how does universal health care impact people's willingness to share information, if I boil it down like that? And let me go through a couple of those. We need probably about 2 hours to discuss it because it's a question that is so deep with human behavior. So on the one hand, if people don't have to worry about being rated out for pre-existing conditions or cost, will they be more free with their own information? And so to start with is, even especially in some states where we have almost no uninsured, the healthcare market is incredibly competitive. We were in Massachusetts again for this Boston Startup Day. There's a very, very small percentage of people that are uninsured, yet the healthcare market is incredibly competitive and dynamic. Sharing information between health plans and hospitals is seen as something that decreases their competitive advantage. So holding data even tighter becomes more important. For whatever reason, we've watched individuals, and I'll just say a little bit about one of the most inspiring government programs that's going on right now at NIH called All of Us. So we're shooting for 1 million people that voluntarily do a DNA sample. So we map the human genome for them, and they also commit their electronic health record data, which we bring together to really understand how profound their genetic makeup ends up impacting their healthcare services. We don't know everything about them. We would know a lot about them. And we're on the way. So we're seeing more people becoming more comfortable sharing their data, but at the same time, there's so many bumps in the road along the way. Whether it's your credit score organization or it could be insurance companies, Facebook, when we see data breaches or something that makes people very nervous about having too much of their data in other people's hands, people start to get a little distrustful. I've not seen the availability of health insurance change public perception too much. I watch it. It changes the way competition gets done because we sort of make benefit levels at a certain way, and it's easier to compare plans and costs. So I think that has been helpful from an economist's point of view. But from an individual's point of view, I so far haven't seen a migration of trust to go from we don't trust and we don't trust our insurance company to, oh yeah, you have to give me insurance so you could have everything you want. I think this is a journey that is probably generational. Older guys like us, I still don't want to give my data to anyone. Kids, my kids' age, they're sharing things on the internet that they kind of feel like, well, everybody knows everything about me anyhow, so what's the next piece of information? And so I think over time we're going to see more and more sharing, but we're not quite there yet. And the tipping point isn't the availability of health insurance, as I've seen so far. But it does make price competition, when you commodify certain benefits, easier to do. Thanks. Yeah. Here, let me come down. It's far away. Oh, actually, I wasn't choosing you. It was a lady in the back, but I'll go with you first. She had a bigger smile.
Do you already have, or do you plan to have, labeled data so you can crowdsource analytics solutions to healthcare fraud?
Okay, the question was, do we have labeled data to make data and analytics available to combat healthcare fraud? And so we do in different ways. And this is interesting because we combat healthcare fraud on many different theaters of engagement. One is nationally for the Medicare program, and we run our Office of Inspector General many, many sophisticated programs that search for healthcare fraud. And then we do this at the state level where they do this for Medicaid as well. it's kind of all over the board. It's not a homogeneous, commodified approach that we put out this data set to crowdsource anybody else's methodology or tools to find it. In fact, healthcare fraud is really difficult because in the way that we just talked about, we're always doing it ex post facto, where we pay and then we go back and chase. And then even the more sophisticated our analysis gets, then we have so many more to go after. And then we go from having large, let's say, I don't know, pick a hospital that is doing fraud systematically and charging billions of dollars. We'll pick off those pretty quickly. And then you're down to a mom and pop home care agency that lacks, say, documentation. The execution part of that's really hard because then you need to get law enforcement and then the courts get involved. And then by the time you get a collection, small companies have a convenient way of going out of business, having no assets to get to, and then they start another business under the other spouse's name. I've seen this happen again and again. So that's how it works in reality. I do like what you're saying, and we don't do that. I'm going to actually take that idea back, that we put out even synthetic data sets that would at least allow other innovators to come and say, hey, here's what we found on this data set. Here's what we could probably do with your real data, and let us go after the bad guys and save the taxpayer a whole bunch of money. I like that a lot, actually. So thanks. I'm going to bring that back. Okay, one more in the back. And then we still have 4 more minutes, so we can keep going. We just achieved quota after this question. Okay.
So I work at the University of North Carolina healthcare system. So we have an ACO, so we're working on the value-based movement. And as you know, the social determinants of health are more important than ever now that we own the risk for these patients. But the challenge with the social determinants of health is that the data is spread across multiple systems. We're an Epic shop. Epic doesn't collect it all in one place very well. How can HHS help us understand the social determinants of health of our patients better by helping aggregate the data in some easier to consume fashion?
Okay, wow, this could be another 2 days. I love this question. So from the University of North Carolina Health System, which, by the way, love the health system, know a lot of people that are working within it and around it, and you guys are really leading the way and being thoughtful about really carrying the risk and thinking about how to care for people. So the idea is, if health systems now, as an ACO, which means we pay them or make their expenditure at risk, if they spend less, they get to keep money and make other investments. If they spend more than they should, then they lose money. And what people refer to as the social determinants of health, it's the stuff that happens outside of the hospital. I actually, and this is probably the best crowd to discuss this concept, I hate that term. Social determinants of health. Who here has a mathematics background? Right, the whole doggone place. Well, what does a determinant mean? Fixed. 1 to 1. One equals the other. We're not dealing with social determinants of anything. We know that we can challenge it. We can distort it. It's the social influences of health that we try to combat. And we're in healthcare, if you're in it for the right reasons, to make people better off, to improve people's lives, to let people live to their true potential. So that's just my takeaway. That's free, that little thought. So we are interested in getting more information out that lets those that hold risk on populations understand that population better and then take care of their populations better. We're engaged, but a lot of these data are going to come from your state government. And we're engaged in an initiative, actually it's going to kick off next week, where we're bringing in chief data officers across states. We'll take the leading states first to provide examples and great practices. We won't know for a while what a best practice looks like until we compare them. But we want to bring those practices together that recognize the importance that impacting health goes far beyond the health care system. And as a matter of fact, in your state, you have a great guy called Aaron McKeithen, that's the Chief Data Officer in your state Department of Health and Human Services, who's leading the charge, who's a great voice on bringing together data and making it more publicly available for those that are trying to improve people's health. So if you see me at the end, I'll give you my card and I could put you guys in touch, because he's doing great work there. And just the nature of your question means you're the right consumer of this data, and I'd like to see you guys get together. And I'll use your question as an example as we bring data officers together. Time for one quick question, this one, and then we got to go. But I'll stick around for a little bit. No, actually, I'm not sticking around. Go to Mona Siddiqui's talk next, and then you'll have all the answers really answered in a much more profound way. Yeah?
Just a follow-up question. So it seems like the main focus is to make the data available so you can get small businesses, large businesses to innovate. But, you know, as you've been doing this, what are other enablers besides making data available to ensure that these startups can be successful to get those innovations out to market? I'm assuming it's just not only the data. What are the other ingredients in the recipe to make this really come?
Man, I couldn't have paid you enough for that question. So the question is making data more available to small businesses to seed innovation and entrepreneurship. Data is not enough. What else are we doing to create a more, say, vibrant environment to grow small businesses and encourage entrepreneurship? So a lot of what we hear is about usually disinformation about our process, right? It's not that people have the wrong idea, it's they don't know, so they create these artifices like these long sales cycles where we don't know what you guys are working on or care about. So we make our opportunities, which are, by the way, published very clearly. You go on the right website, look for the right thing, and everything that we're asking for is plain as day. The process is delineated. It's complex, but it's not confusing. So we're the interpretation layer. We're making it easy to consume, and we're going out to these pockets of innovation around the country to talk to those that are engaged in private sector endeavors that we want to win back that innovation so we get it on our problems, not just private sector problems. So for example, we'll be in Chicago and Nashville next month. Again, hotbeds for what we care about, healthcare and human service innovation. And we go and make this information available, and we bring people to work with them. In our first startup day, we had somebody from NIH talk about the SBIR program. So it's a small business program. At that event, one of the teams that was there to give a pitch ended up applying, and before we started our last program, made an announcement they actually got funded, and their business is now beginning to roll. And so, again, we have enormous amount of resources that's available, and it tends to get focused on the people that know how to navigate the system very well. Our goal is to make the number of people and businesses that know how to navigate the system this wide instead of just this wide. So that's what we're doing. No one gets any special treatment. It's just what we have available, we make it more well understood. We got to go. Thank you guys very, very much. I appreciate your attention this morning.